Welcome to the Rob Call Bottom Up Show, available on Pacifica Radio Network, Progressive Radio Network, iTunes, Stitcher, SoundCloud, at opednews.com/podcasts. And I'm very excited to have two guests on the show this time. But both, I think, are repeat guests, too. Wendell Potter is founder of tarbell.org, which is an investigative news site, and he's the president of the Business Initiative for Health Policy. Chuck Pennacchio is a history professor at University of the Arts, Philadelphia, and he's the coordinator of I think I got that wrong, the single payer, one payer? One payer. All right, he's a coordinator of the single payer state network. So welcome back to both of you. It's great to have you here.
Thank you, Rob. Good to be back.
Thank you.
Yeah. So
great to see you.
What I want to talk about is Medicare for all, single payer, one payer. There's a lot of exciting conversation going on about it. You've got the pushback that we knew was going to happen coming from the industry and from the people who support the industry, namely the centrist candidates who say it can't be done and who say that we have to just embrace Obamacare and never let go of that model. So what I wanted to do is spend this time with you talking about what really is going on, what it's all about, what are the answers, how are the insurance companies and their allies, the pharmaceutical giants, how are they going to push back and fight back and get an overall picture of it. So, Chuck, you sent me a document that is really great. That's like talking points that basically respond to a ton of arguments that people give when they say that Medicare for all won't work or whatever. And there are a bunch of different reasons. So maybe we can just go through those between the two of you and discuss them and help people listening to this when they get argument from anybody to have answers. That's what I'm hoping to do here. So the first one is, it's going to cost too much money. We're going to have to pay more taxes. And what's the response?
There's already more than enough money on the table. Much of it we're wasting. And once we streamline out that waste, become much more efficient, strip out the waste, fraud, abuse, bring bulk purchasing for pharmaceuticals. We'll be able to afford a universal healthcare system based on the money that's already on the table, and save money, and save lives, and create jobs.
Yeah, but there's that study that said it was going to cost like $10 trillion over, or some $30 trillion, some ridiculous number, and that it says that people are going to pay more taxes. So what's the deal on that? How do we answer that?
Well, actually, the Mercatus Institute proved a lot of our arguments already. They actually, their own study, which was a skewed study, demonstrated that we will, in fact, save money with a single-payer system, Medicare for all.
So
their own study.
Yeah, Wendell.
The reality, too, Rob, is that we currently spend $3.5 trillion on health care in this country. That's the equivalent of about $10,000 per person, which is far and away more than any other developed country spends on health care. So let's just say that $3.5 trillion right now, and let's just assume that there will be no increases in medical inflation, which of course is ridiculous because it's been going up rapidly. But even assuming there was no increase, we still, in 10 years' time, would be over $35 trillion. So as Chuck was saying, even their study shows that we would be saving money. We'd be saving a lot more, quite frankly, and we'd be covering everybody. Much of what we spend on healthcare these days is wasted or is spent in ways that has nothing to do with the delivery of care. A lot of money goes to cover profits of the big for-profit health insurance companies, drug companies, big for-profit hospitals, and is eaten up by the absurd amount of administrative cost in our system, which is unique in the world. No other country in the world, certainly the developed world, spends as much as we do just on paperwork and creating barriers to care, quite frankly. About a third of what we spend of that $3.5 trillion goes not to help people get better or to stay well, but on administrative expense.
And from what I understand, the model that is being talked about, it provides a lot more care. It's not just health insurance, it's dental insurance, it's eye care and eyewear.
Yeah.
And that's a huge additional expense that most people are paying. So they would basically, but it gets back to that question again. You're saying that the overall cost will go down or stay the same, but everybody is saying, well, you're going to pay more taxes. And what is the answer to that?
Well, it's true. And the opponents always use it. I call it playing the tax card. What we need to do is help people understand that what we currently are paying is a private tax. It's a tax that comes out of our pocket and our employer's pocket, if we have employer-sponsored healthcare, that goes into these big companies that skim so much of it off the top. We need to have a different way of thinking about how we're spending our money, rather than going into the pockets of shareholders and executives, which is what is happening right now. Our money will go into a single pool, and it'll be administered much more efficiently. It's a publicly financed system, so obviously, if it's publicly financed, that means it's financed with taxpayer dollars. But you can do it in a way that is much more equitable and much more efficient than what we have now.
Now, Chuck, you developed a model looking at Pennsylvania where it was going to cost people 3% of their income. Is that right?
That's correct. Yep. But again, that eliminates, as Wendell was referencing, it will eliminate premiums, copays, and deductibles. So what people are currently paying out and what employers are currently paying out, those monies will disappear. In other words, they won't have to pay those monies. Instead, the individual in Pennsylvania will pay 3% on all sources of income, 3%, and then you're covered.
So for example, if you make $50,000 a year, you're going to pay $1,500 a year for health insurance, as compared to possibly paying as much as $10,000 or $12,000 a year right now.
Not even higher than that. Yeah, the savings would be real.
Are there copays with this model?
No.
No copays. And
correct.
So for somebody making $50,000 a year, they would pay 15% of what they are currently paying. Now, if you're making $200,000, then you're going to be still paying only $6,000. It's still good if you're making $200,000 or $300,000. Even you'd have to be making like $330,000 to just pay taxes that are equivalent to what you're paying for the health insurance now.
Yeah, the number we came in with.
It's for an individual, but it's for now. Yeah, go ahead.
I think the break point is about $135,000. In fact, people who make in excess of $135,000 will be paying marginally more in the form of overall costs, but what they'll be getting in return is lifetime comprehensive care, as we've described here. And they won't have to be concerned with the copays and the deductibles that currently exist in the insurance system. And the insurance system as well, and Wendell and I, we talked about this the other day, there are now 87 million Americans who are underinsured, meaning that they simply cannot afford the healthcare cost, though they have health insurance policy in their hands. That's a phenomenon unheard of elsewhere in the world. In addition, there's also the question of medical bankruptcy, which is throwing millions of Americans into absolute economic hell.
Now, are we talking about family income? So you're saying $130,000. Is that for a family or for an individual?
That's an individual income.
All right. So if a family makes $130,000, then it would be a better deal, right?
Yes, correct.
Okay. So it's amazing, really. It seems like such a better, but what about if you're an employee and your employer is covering your health insurance?
Well, and Wendell, do you want to pick that up?
I'll start. You know, the employers in this country are beginning to wake up to the reality that they just can't keep staying in the game of offering benefits. And the organization that I'm president of, the Business Initiative for Health Policy, makes the business case for moving to a Medicare for all type of healthcare system. And that is, and employers are beginning to wake up to the fact that they have no control over these ever rising costs of providing coverage to their workers and their workers' dependents. And the money that they're spending is going, once again, into the pockets of big executives and shareholders. And these executives have sold them a bill of goods over many years, persuading employers that they can control healthcare costs while providing good and valuable coverage to their workers. Both are absolutely false, and we're seeing the evidence of it every single day. Any employer who looks at his or her bottom line sees what's happening, and they're seeing that they're being forced to shift more and more of the cost of the premiums and the cost of care to their workers. If you look over time at what's been happening to premiums, just premiums in the workplace, you'll see that employers year after year have been shifting a little bit more of the total cost of premiums to their workers, to the point that workers are now having to bear a greater burden of the cost of that insurance, that coverage. But they're having to spend a lot more out of their own pockets in the forms of higher deductibles. So what has been going on, there's a term in the insurance industry called benefit buy-down. And this is a term that describes, an umbrella term that describes the many, many ways that insurance companies have been forcing employers to devalue the health insurance coverage that they have, one way or another. We can tick them off, but it's been gradual, but it's been dramatic when you look at what's been happening over the course of the last few years.
Now, that to me brings up a major lie that I think the insurance industry has been selling, and that is the idea of keeping the policy if you like it. Because really what's happening is every year the insurance companies renegotiate, they change the rates, they take away some benefits, they charge you more for the copays, and you end up not with the same policy, because if you kept the exact same policy, they would tell you it's a lot more money. Because I was an employer and I had employees, and every year it would change. There is no such thing as keeping your policy. That's a lie, right?
It's absolutely a lie, and the rhetoric goes back to the last healthcare reform debate when President Obama was behind healthcare reform, and he unfortunately made a big gaffe by saying if you like your insurance, you can keep your insurance, without realizing that we have no control of it and haven't had in a long, long time, if ever. The reality is that if you get coverage to the workplace, it is not you that decides which insurer that you will be working with. It is your employer. And it is your employer working with the insurance company who decides which plans you'll have access to. And increasingly, it is a choice between which high deductible plans you'll have a choice of. When I went to work in the industry more than 20 years ago, this was back in the era of managed care, we saw this beginning. Employers would shift only to working with one insurance company, and employees would have no option of choosing anyone other than what the employer chose. But as we moved into the era of these high deductible plans, it's gotten even worse. Our managed care plans that most of us were in for several years, they all went away. And all of us, almost every single one of us has been moved into a high deductible plan. So we absolutely have no choice. It's a rhetorical device that our opponents are using, and it is an absolute lie. We have increasingly fewer choices of the kind of coverage that we have.
Now let's talk about insurance for people who are already on Medicare. How will it affect them? Now, I did some of the numbers, and if you look at the 3% tax, that means that if you're making, if you're retired and you have an income of $50,000 a year, which is probably way higher than the average retired person, you're going to be paying $1,500, which is about $125 a month. And that's for complete coverage of dental, vision, and all deductibles. Now, right now, it costs more than that just to have the bare basic Medicare, which it requires you to pay a 20% or more copay, requires you to pay for your medication, and doesn't pay anything for dental or any of those things. So I think unless you're a very wealthy retired person on Medicare already, you're probably going to cut your bills dramatically. And if you've got any expenses for medication or things like that, you're really going to do a lot better. Am I right on that?
Yeah, you are right. It is a slippery slope because of the privatization of Medicare. Most notably, Prescription D legislation that passed in 2003 became just a mass subsidy for the pharmaceutical industry at the same time that they've become a completely deregulated industry.
Right.
And so it's a bait and switch. It's a complete bait and switch. So Medicare, traditional Medicare that came out in 1965, was a very good program. Not entirely comprehensive, but it was not privatized the way that it's been, especially during the George W. Bush era. We've seen a real setback.
But if we go to Medicare for all with the model you're talking about, then that'll change.
It's not the model. It's an improved Medicare for all. And the key word really is improved. Pramila Jayapal has taken what was John Conyers' H.R. 676. The new bill is H.R. 1384 and has enhanced it and has wrapped around these deficiencies and these privatized elements that had come to exist over the last, say, 15 years.
Great. So one big argument that people that have is that Medicare for all is administered and provided by government, the evil word government. What about that? And the conservatives are going to say government just screws things up. It makes things worse. It takes over. It's socialism.
And that's a term, of course, that they use a lot. Chuck used the term slippery slope, and they will tell you, and they will tell us, and we will hear it many times, that this is a slippery slope towards socialism. But the Medicare program itself was, created soon after, or some years after the Social Security program was created. These are programs that are social in nature, in that they provide guaranteed benefits for people, certainly as they grow older. The government provides incredibly important services in our lives, whether we're talking about public schools or roads and highways. There is a lot that we rely on our government, and we don't have these arguments about they being socialized programs. So it's just a talking point that they will use to scare people. In my old job, we used to call these campaigns F.U.D campaigns, fear, uncertainty, and doubt. And that is a comprehensive term or an acronym that describes exactly what they have done for many years. These campaigns are evergreen. They've been using them for decades. In fact, the same arguments, Rob, were used back in the 60s when the Medicare program was being developed and was ultimately passed, of course. The American Medical Association hired Ronald Reagan to be its pitchman and to try to scare the bejesus out of people by saying this was socialism. Well, what has been created has been probably one of the most valued programs in American history.
Who was the president under which Medicare was created?
It was President Johnson. It was
right.
The administration of President Johnson. So more than 50 years ago.
Yeah. Okay. And another argument is that there won't be competition, and it'll make it more expensive.
I'll take that one. What we have is supposedly competition, but competition in health insurance works exactly the opposite of the way competition theoretically works in other sectors of the economy or other segments of the economy. When you have multiple insurance companies in the marketplace, None of them has anywhere close to the market size that even our current Medicare program has. They are often impotent in trying to negotiate favorable rates with healthcare providers, in particular large hospital systems, but certainly with drug companies. And the more of these insurance companies that you have, the less market share that they have, certainly at the local level. So it's just, when you look at what is really going on in the marketplace, you realize that these so-called competing insurance companies cannot control healthcare costs. It's been a ruse for decades. But here's the other thing. They don't really want to control healthcare costs. And here's why. As healthcare costs go up on the provider side, whether we're talking about the cost of a hospitalization or prescription drugs or a visit to the doctor's office, these insurance companies, because they're at this point pretty much the only game in town for most of us who are not eligible for a public program, they thrive on these ever-increasing healthcare costs. So it's a big scam that they've got going, that they control healthcare costs. They not only cannot because they're not big enough, but they don't want to. As healthcare costs go up, they price premiums a bit above what they anticipate, what they call medical trend to be. So that's why we see these premiums go up as they are every single year. It is not because they somehow magically have been able to or are able to control healthcare costs. They don't. But as healthcare costs go up, they're able to price their premiums a bit higher. And they demand it. It's kind of like demanding ransom. They get more revenue as a consequence, so there's more money for them to work with to convert to premiums. It's a big scam.
All right, I'm going to do a brief show ID. This is the Rob Call Bottom Up Show, and I'm going to just pause for a minute because I'm going to insert a bumper in here, so just be quiet for 10 seconds. And my guests for this show are Wendell Potter, who's the founder of Tarbell.org, an investigative news site, and he's also the president of the Business Initiative for Health Policy. And Chuck Pennacchio is a history professor at University of the Arts and coordinator for Payor States Network. So we're talking about some of the reasons that people say that Medicare for all or single payer won't work, and getting answers so that when you have your conversation with your right-wing aunt or uncle or cousin or whatever, you can tell them the facts. So one is, or I should add, your neoliberal, moderate, Republican light Democrats that you know, who say we can't do that. And I call them the can't-doism-ists. So one is we need to take small, safe steps. That's what we need to do because it's too much of a change. What's the answer to that?
Well, and I'll take this, Chuck, and you can weigh in. We can't afford to take these small steps anymore. That's what we've been doing. We've been tinkering around the edges for decades now. And frankly, that's what the Affordable Care Act was. It was an improvement over what came before, but it essentially kept the system in place as it was. And big chunks of it were written by insurance companies and big hospitals and drug companies to make sure that their needs, their profit needs, were taken care of. And we've seen the evidence of that as these companies have turned in record profits year after year since the Affordable Care Act was passed. So we've done that, Rob. That's been the approach, and here we are in a situation in which we still have 30 million people who don't have insurance. We have probably 50 to 80 million Americans who have insurance, but they're underinsured and simply can't use it. They're paying premiums, or taxpayers are helping them pay their premiums, and they can't use their insurance. So why would we keep doing that? Why do we want to keep tinkering around the edges? I've often said, let's look at this as, okay, you have an old car. And you think you can't afford anything else. You know you need new tires. You know you need the oil changed more regularly. You know you need a new transmission, but you can't get it. You don't have the money. That's analogous to the current healthcare system we have now.
We've got a clunker that is so broken that it's costing us a fortune, and we can't use it half the time.
Exactly. So why do we keep doing that? When we know we can actually do better, we can afford a better car, and it'd be much more reliable, much more secure. It's not going to break down on us because under an expanded and improved Medicare program, it's there for you. You don't have to worry about losing your job and losing your insurance.
Now, let's just talk about that one thing about losing the job, because this, I think, is such an important one. I really believe that, in a way, we have health insurance indentured servitude.
Yes.
Because you can't leave your job because you won't have insurance. That means you're stuck in a job that you hate.
Yes.
If you have Medicare for all, you don't have it attached to your job.
Yes.
If you leave
Absolutely.
the job, you're going to keep your health insurance, and you can try something different. You can be an entrepreneur, start a small business, and that small business is where the engine of our economy really does the most effective work. The other side of it is the companies that are paying this fortune for health insurance for their employers, they're at a disadvantage in competing with all the rest of the world, where they are dealing with big companies that don't have to deal with that because their country provides the health insurance for their workers. So
Absolutely.
we need to get rid of that.
The phenomenon you're referring to there is job lock, and it freezes up the economy, and it freezes up, as you indicated, the entrepreneurial spirit, the creative capacity of workers, and the ability for people to really stretch and to live a better life. It really is as you said, an indentured servitude-like system, where people are working more and more hours, more and more jobs, getting less and less compensation, and paying more of their less compensation out of their pocket for rising copays, premiums, and deductibles. So it's lose, lose, lose. And for the employers as well, to your point, Rob, they're frozen because they cannot make capital investments. They cannot hire new employees. They cannot budget 5 years out because they simply don't know what their healthcare costs are going to be over that time period. And as you said, they are unable then also to compete among other businesses around the world, because those other businesses have health insurance, have healthcare that wraps around their employees and their businesses.
Now, if I'm doing the numbers right, if let's say it's a worker who makes $50,000 a year, if they had to start paying taxes on that at $1,500 a year for an individual,
Right.
it would still be $1,500 if it was a family, depending on that income too, right? Or would it be 3% for each individual?
Well, the 3% tax here is on each individual. Right.
So it could be as much as $6,000 for a family of four. That's still a lot better than what it would be for a family of four on the other way.
No, if you were talking about $50,000 of income, just whether it's 4 people making it or 1 person making it, it still is $1,500.
Oh,
Not
so
to
it is the
confuse the
same.
number.
It is the same.
Right.
Okay. So but the bottom line is, if the employer's been paying that $10,000 for that individual or that family, the employer doesn't have to pay anything anymore, and the employee can get a raise.
That's not quite true. Well, just to be clear, at least the legislation in Pennsylvania, it varies. We don't quite know what the financing is going to be for Pramila-Jayapal's 1384 yet. They're taking this in steps at this point. But we in Pennsylvania call for a 10% employee payroll tax. Now compare that to what the average business is already paying, which is somewhere in the neighborhood of 22%. So in fact, employers are going to go from paying 22% to those who do cover their employees down to 10%, and the individual is going to see their average costs right now, which is about 8% in total out of pocket of all costs. And that's going to come down to 3%.
So
You're
the employer is
going
going to pay, and what about somebody who's self-employed?
Well, that is a situation where like you're talking about like family businesses. Typically family
or an entrepreneur or somebody, I'm a writer. I have a small business.
Oftentimes they simply do without health care. I mean, they're one banana peel slice from getting in a real precarious situation. So many of these startups, they take the risk of going without insurance simply because they consider that it's a risk worth taking. But the reality is that it's a very dangerous situation that they've set up for themselves.
Well,
And so
but for example, my business, it doesn't make any profit. Any profit goes to me as pay. So it has a
Right.
zero profit. Is the business paying it on payroll, or is it paying it on revenues or profits? You said payroll, right?
It depends on what kind of a corporation you've set up. Wendell, do you want to take that?
It does, but I think the broader point here is that if you are someone who is self-insured, obviously self-employed, you may have no employees, you may have a few. You would pay into this program, but I think it's important to note here too, as Chuck noted, the federal legislation doesn't have the provision yet of how do you pay for it. So that's still yet to be determined. Now, some legislation at the state level, as Chuck is describing, it does have some mechanism for raising the funds, but we don't know exactly what it's going to look like. But for the majority of people who are sole entrepreneurs, who are sole proprietors or have small businesses, depending on what their income is, they would pay something that we would call it a tax, but it would be in lieu of premiums. But everyone would be covered. And I think that whatever the mechanism is for paying for this, I trust it will be a progressive taxation system in which those who are making the least, and often those are people in startups who don't make a lot of money, would be able to get coverage at long last. A lot of entrepreneurs, as we know, who are trying to make a go of a small business or some new venture, they forego their insurance because it's just too expensive. So it will free up a lot more people to try to be more entrepreneurial in the future.
What would happen to people on Medicaid?
It would be rolled into Medicare. We're talking about, when you talk about single payer, you're talking about one payer. And in the Medicaid system or Medicaid program, you have a partnership, if you will, between the federal government and state governments, and the benefits vary and the requirements vary from state to state. And some states have not expanded the Medicaid program to cover others who are eligible in the states that have expanded it. So it's the Medicaid program certainly benefits a lot of Americans. Many millions are enrolled in the Medicaid program, but the benefits vary. The value of the program varies from state to state. They would become part of this improved and expanded Medicare program.
Okay, but some might argue that by doing this, you're going to dilute the value of it and make it so that we no longer have the best healthcare system in the world, and we won't have access to the kind of quality. I mean, there's always people saying, well, look at the Canadians, they come to the United States for healthcare.
Yeah, and thanks, Rob, for mentioning that, because that's a lie I used to tell in my old job. It was one of the things that we did to scare people. It's part of that F.U.D campaign I mentioned earlier. It's not true. Canadians do not flock across the border to get care in this country. Since I left my old job, have spent a lot of time in Canada. I've spoken from coast to coast, and I have not met a single Canadian yet who told me that he or she came to the U.S. for care, or that they would even consider swapping theirs for the U.S. healthcare system. Now, all that said, there's no doubt that we in this country have some of the best hospitals and doctors in the world. We do. We don't have a monopoly on it, but we have some good healthcare providers. The problem, and the growing problem, is that fewer and fewer of us have access to them.
Right.
We have the most means of rationing, which is rationing care by ability to pay. And that is not known anywhere else in the world. And increasingly, more and more of us are unable to have access to these great hospitals and doctors.
Yeah.
Yeah. The truth is that one of the fastest growing travel sectors in the United States is medical tourism. Americans, in fact, are getting their health care abroad, especially expensive surgeries. I mean, they're traveling to places like India, they're traveling to places like Taiwan, simply to get health care that is far more affordable. In fact, Wendell knows this. They actually roll family vacations into this. It's more affordable to take a family vacation in faraway places and get the medical care that you need, as opposed to simply paying the medical costs here in the United States. It's the real irony, and it's the real twisted state of affairs that we've arrived at right now. But to Wendell's earlier point, what improved and expanded Medicare for all really means is that we've made a decision as a society that we're going to share this risk that we all share, that we all have in common, that it's restoring a public good. And healthcare is not like any other commodity. This is not something that you choose to pursue. You need healthcare, you need it, that's something you have to get. And it's a shared risk in our society. We don't know from one day to the next what our medical situation is going to be. It's a very mature society that makes that decision, and every other society in the world has made it except ours.
And people die. People get sick.
Yeah.
Tens of thousands of people die because they don't have health insurance. Their lives are destroyed because they go bankrupt. We're not talking about tens of thousands there. We're talking about millions.
Exactly.
Even people with health insurance, because the health insurance isn't enough.
It isn't enough. And increasingly, it's not enough, even if you have your coverage to the workplace. Again, the Commonwealth Fund is now estimating that close to 1 of every 3 people who have their coverage through the workplace are underinsured. So again, that's one thing. Years ago, my former CEO, he was asked in a leadership meeting what kept him up at night, and he said he feared that one day people, and in particular employers, would wake up to realize, again, that they've been sold a bill of goods. He didn't use those terms. A term he used was disintermediation. That's what he fears. And by that, it's a big fancy word, 50-cent word, that means that people will come to recognize that a middleman is no longer needed. And insurance companies are a middleman. They're not necessary. We have no system in the world that is like ours, with so-called competing for-profit insurance companies. No other country has looked at what we've got and said, hey, let's adopt that. That's never going to happen. But the reality is that every year our coverage, our private coverage, is being devalued, and employers in particular are waking up to that. And you mentioned earlier, employers. The founder of the Business Initiative for Health Policy is a significant employer in the Lehigh Valley of Pennsylvania, and he's done the math. He knows exactly how much he's having to pay now to offer coverage to his benefits. He's tried since the beginning of his firm to offer good benefits. He now has estimated that it's costing $13.50 per hour per employee to offer coverage to his workers. And he's having to explain that to his workers and say, I would love to give you a more significant raise, but I'm having to spend the money that you would be getting in a raise. It's going into the pockets of these insurance company executives and their shareholders. So what's fair about that?
So why aren't most employers in the United States raising their voices for Medicare for all?
They're going to start doing it. And that's why we exist, the Business Initiative for Health Policy. More and more, one by one, they're beginning to wake up to this. And it's not just the small guys. It's the reason that Warren Buffett and Jamie Dimon and Jeff Bezos got together to form this new nonprofit that they've formed. It's not so that they can get in the business necessarily of selling insurance. It's what can they do to keep from having to pay more and more every single year for coverage for their workers. They've caught on to this lie that they've been sold, that insurance companies are necessary. Now, some might say that's a free market solution or what's going on in the private sector. Well, more power to them. If they can figure out a way in our current system to save a few bucks and disintermediate the insurance companies, I'm all for it. But most of us don't want to work for have that opportunity. The rest of us need to have a break as well too, and that's what Medicare for All would do.
Right. There's threads.
Go ahead,
I just
Chuck.
want to pick up a quick thread there. every time we talk about the free market, I think it's important that we clarify what it is we mean with Medicare for all. The free market is giving you the option to choose your provider and your hospital.
And right now, many people, especially if they have less expensive plans, they can't. They're on one tier of one hospital with one provider. Right. They've got to get referrals. They're really locked in very narrow ways, and there is no freedom of choice for health providers. You can't go to the best hospital. You can't go to the best doctor. You got to go to the one that your doctor refers you to, and your doctor very likely is going to be paid based on how little he spends on referrals too.
Absolutely.
Looking at this is something that magicians use all the time. It's called misdirection. And a lot of the Republicans talk about keep your eye on premiums. We want to do something that can bring down the cost of premiums. Insurance companies and others are all in on this game as well too, to try to get us to look here at the cost of premiums. And we can bring your costs down by putting you into higher deductible plans. What they're doing while you're looking up here, they're picking your pocket and they are taking away something of great value from you while your attention is being diverted elsewhere. They're picking your pocket in so many different ways, including these so-called limited networks we've just been talking about. Increasingly, health plans have narrower and narrower, sometimes they call them skinnier networks, and that means that you have far fewer choices of doctors and hospitals. And here's the other thing. It's become so complicated that you might go to a hospital that's in your network. You might need to have surgery. Let's say you have to have an operation. You might go to the hospital and you have to be put under by an anesthesiologist. And then when it all is done, you wake up hopefully, and you go home, you're going to get a bill, very, very likely, from the anesthesiology group, because even though the hospital was in network, the anesthesiologist was not. So people are getting these surprise bills. It's unbelievably, stupendously stupid that we're putting up with a system like this.
I agree. So we need to do another show ID, and we're going to just pause because I'll put the bumper in for it. And my guests for this show are Wendell Potter and Chuck Pennacchio. And Wendell is the founder of the tarbell.org, and he is the I lost my paper that has all the information on it. Oh, here it is. And Wendell, my guest for this show is Wendell Potter. He's the founder of tarbell.org and an investigative news site, and he is the president of the Business Initiative for Health Policy. Chuck Pennacchio is a history professor at University of the Arts, Philadelphia, and he's the coordinator of Payor States Network. And we've been talking about how to have answers to the objections that people give to Medicare for all. So another one is that there won't be enough doctors to go around. People in the insurance industry will lose their jobs. What's your response to those?
Oh, a couple of things real quick. The reality is that when medical students enter their programs, so many of them want to get into primary care. They want to be family docs. They want to wrap around the entire health of their patients. But as the cost of their education skyrockets, they end up funneling into these specialties. So what the current system does is it actually drives down the availability in the pool of primary care family physicians. That's a real problem. And what Medicare for all, improved Medicare for all will do is it will make it viable for medical students to practice medicine in a way that restores that primary care element that we're currently missing.
How does it do that? I don't understand that, Chuck. I mean, why would
it's the rising medical costs associated with school, medical school. I mean, these are young people who exit medical school with $300,000, $400,000, $500,000 in debt, and then what they end up doing is they end up joining these big hospital networks, and they work under contract. They do what's called assembly line medicine. which in the case of the patient, they spend less and less time with you. I mean, I was in the doctor's office the other day, and there were 30 people piled up there, and they all had the same appointment time, 1:15. They were all there for a 1:15 appointment. What does that mean? They just stack patients up because they can't afford to deal with lost patients or canceled appointments. And so what happens is you have this phenomenon of more and more patients with fewer and fewer, with less and less quality time with doctors. And that also has a depressing effect on doctors who actually want to practice in states with complicated bureaucracy like Pennsylvania. And so they're spending more and more of their time haggling with insurance companies and less of their time doing actual medicine. So, I mean, all these phenomenon create a real problem in terms of lack of choice of physician and then the quality of care once you actually get locked in with a physician. Improved Medicare for All will reverse this phenomenon and give you greater choice as well as quality care.
And there will be enough doctors?
Absolutely. Absolutely. The first state or the first place to adopt universal health care, Medicare for All, will be a magnet for doctors around the country who are just frustrated as hell dealing with these growing bureaucracies, both on the public and the private side.
Wait a second, because we're talking about federal legislation, but you just said first state. And I know that in Canada, there was one state where they started their single-payer health care, and then it mushroomed to the rest of the country. And I've always figured that would happen in the United States, that one state is going to be the state that starts it. And I always figured that state, all of a sudden, people are going to want to move there because it's going to be a better deal, and they're going to be free from the indentured servitude of working for an employer to get health insurance. And it would probably really affect the neighboring states.
Yeah, we're at a very exciting moment. I mean, as the leader of the Payor States Network, or the leaders of state campaigns, I mean, we're looking at California is really at a tipping point. Washington State, Wisconsin, Minnesota, Maine, New York. These are all places where we could adopt universal health care within the next couple of years, potentially. And once one of these states does adopt it and models it, it'll set off a light bulb in the minds of more people than we can imagine. Because right now we're being told by the corporate media that this isn't possible. But once it is adopted at the state level, and I do believe that the chances are greater that it will be adopted at a state level before anywhere else, then I think we're going to have a real breakthrough. Wendell's traveling the country. I'd love to hear some of your stories about states that you're looking at, Wendell.
Yeah, I do. I travel all the time. In fact, I'm going to California on Sunday, and I'll be out there in San Francisco and Los Angeles, meeting with a lot of folks who are involved in the effort out there. And it's all across the country. I go to all these states very often. I speak to audiences large and small all over the country, and you are seeing unprecedented support for moving forward. And as Chuck is noting, there is no one path to get there. It can start at the state level. It can start here in Pennsylvania or in California or somewhere else. It could start in Washington. But you're also right that the system in Canada started in one of their smaller provinces, Saskatchewan. And it wasn't too long before other provinces took notice and said, well, I want what they've got. And it eventually became a national program. There's some variations from province to province. But I'll tell you one thing, the Canadians, the person that they revere most in Canada, he's been named as the most popular Canadian of all time, is a former Baptist preacher by the name of Tommy Douglas, who was premier of Saskatchewan and who was the driving force behind that province moving to their single-payer healthcare system. He's the most popular Canadian of all time.
Wow.
And I mean, building on that, we're working very closely with Ro Khanna, who is the congressman who will be introducing congressional legislation to allow the states to move forward seamlessly, both in terms of economics as well as legal questions. And so we're working very closely to get a bill called the State-Based Universal Health Care Act. It'll be introduced in the next 4 to 8 weeks, and that will allow states to move forward in a much more coherent and, again, seamless fashion. So we're very excited about where we are at this point historically.
So another objection, and I've got a list of 3 of them here. I'll put them all together. some people deserve to be poor because they're lazy, and the rest of us hardworking people shouldn't have to use our hard-earned money to pay for their health care. I'm a single male and don't plan to marry and have children, so why should I pay for some woman's prenatal care? If I don't smoke and I exercise and eat properly, why should I pay for the health care costs of an obese smoker?
Yeah, let's start with that. One, that there are too many lazy folks out there, so why should my tax dollars go to support them? Well, that's just foolish thinking, of course. The first country in the world to really move to a universal system was Germany back in the Bismarck era. And he recognized that a healthy...
Bismarck, that's like 1880s.
Exactly.
Yeah.
He recognized that to be a strong Germany, you need to have a strong and healthy population. So they've been at this for a long time, and they've done quite well. And that's what we need to look at. One of the things that people don't realize is a lot of recruits are turned down because of poor health to this day in this country, whether it's poor physical health, often dental health, believe it or not, is a big reason why a lot of recruits are turned down, because they just have abscessed teeth and bad gums. And that's another reason why you need to have a program that covers dental. So it's just foolish. And they also, some of these folks who say that, think this is somehow a zero-sum game, that if somebody gets coverage, then I won't get mine, or my coverage won't be as valuable. What we're talking about here is something that will improve the value of their coverage and their care. So they're not only not giving something up, they are getting something of much greater value at less expense.
Yeah, and it's a race.
Go ahead, Chuck.
I was going to say, this is also race-based dog whistle politics. I mean, it's not so subtle that we're being divided along racial and class lines, and this is, and as well as the whole immigrant question. And this is something that unfortunately wraps around the healthcare debate and gets people from thinking clearly about the benefit that it will provide, as Wendell said, to their family, for their security, for their opportunity, for their ability to function in the world with some ability to predict what's going to happen, week in and week out. This is going to benefit our communities, as Wendell said, as in the case of Germany. It's going to benefit the entire country. So what we need to do is we need to counter these dog whistle, race and class-based arguments with a vision, with an optimistic and realistic view of what improved Medicare for all would actually mean for all of us, and bring us together as a nation for once.
You mentioned also, Rob, this guy who says, why do I want to have a health policy that offers maternity benefits? I'm not going to get married. And who cares about prenatal care? Well, there's a good chance he's on the earth because his mom got prenatal care, or at least was able to get the care that made it possible for him to exist. But you also need to think a bit beyond your own self right now. Might be that you change your mind and someday you do have a daughter, but you may have a sister, you may have a niece or someone. So it's not all about you. You need to think a bit beyond that, and think of us as a society and what makes us a better place to be.
Another one. Why should I pay for health care for undocumented immigrants who shouldn't be in the U.S. in the first place?
Now, that's something that you have to, it's going to be a debate. It's going to be a part of what's going to be discussed at both the state and the federal level. Certainly in California, that's something they've been wrestling with. Immigrants are a significant percentage of the California population, as it is in Texas and many of the states, and certainly increasingly northern states as well, too. These people are here. They get care when they get sick or injured. And in many cases, they do, and they may or may not, and chances are do not, have the ability to pay for the care that they get.
So they end up going to a hospital, which costs way more than just being able to go to a doctor.
Exactly. And so who pays for that? It is a way of shifting the cost to others, to people who do have either insurance or some ability to pay. So there's no such thing really as uncompensated care. We talk about that, but somebody pays for it. And the way the system is, if you don't have some means of providing for care for people who are not citizens in this country, then you just have to recognize they do get sick, they do get injured, they do have often the need for expensive care. And you can look and see what other countries do, how they handle this as well too. You can be on a trip to the UK, and one of our writers at Tarbell was recently in the UK. His daughter was in a very fine school there, graduating. He got very ill while he was there. He was cared for by some of the best hospitals and doctors in Cambridge or Oxford, I think, in England, and had a hospital bill that was just tiny. He wasn't an immigrant, but he was someone who was there and who needed care, and they took care of him. That's what you do in a civilized society.
That is what you do in a civilized society. So are there any other objections that I haven't brought up that are important for people to think about?
Well, one question you did raise earlier that I don't know that we addressed was the displacement of insurance employees. That's true. But what we've done in Pennsylvania, and I hope it's a good model for other states, Wendell's familiar with this, is that we're going to take care of these folks and give them a golden parachute of up to $60,000 toward their existing salary for the next 2 years, as well as to give them monies toward job retraining. Because what we're going to, in fact, see as we move toward improved Medicare for all is we're going to see more and more people getting health care. And so it's going to be it's going to be a jobs creation bill as well. So we're going to be seeing a transition, but we need to make sure that people are not damaged or hurt in an unfair way because of these changes. So we do need to take care of people who are displaced, and we in fact will do that.
Yeah, absolutely. It's just transition. I think that's a term or something like that. It may not be the exact term, but both the Sanders bill in Washington, the Jayapal bill, would set aside some funding to make sure that people who would be facing a job loss would be trained or otherwise taken care of. But one of the things to keep in mind is that increasingly a significant percentage of the people who work for insurance companies are doctors and nurses. Tens of thousands of nurses have been recruited by these companies. And what do? Every day they're on the phone with nurses who are working for doctors. Neither one of them is doing anything to provide care. They're just fighting with each other to determine how much is going to be paid for how much the doctor or the nurse practitioner actually, what kind of care is actually provided. So this is an example of the unbelievable misuse of resources and waste in our system. You've got people who are trained to care for people at the bedside or to take care of people who are, and they're doctors and nurses, working as bureaucrats in these companies or for hospitals and doctors' offices. This is crazy. And most of the time, these people they're paid to obstruct and to make it more difficult for people to get the care that they need. That should go away. And these people should be, if they went to school to become nurses and doctors, damn it, that's what they should be doing.
Yeah. Okay, so we've got just a couple of minutes left. Wendell, I'm particularly interested. You worked for Cigna, and when Michael Moore came out with his movie Sicko, you were appointed to be the guy who, how would you describe what your job was there?
Well, it was, and I had plenty of compatriots. Our job was to make people think that Michael Moore was un-American, that what he was proposing was, and that he himself was out of step with American values, and that we did not want to believe what Michael Moore's movie was all about. And we did a darn good job in many cases of getting people to believe that he was not like the rest of us. So we did.
Now you're talking about there's going to be this F.U.D campaign, which is fear, uncertainty, and doubt. How are these big insurers going to respond to these increased efforts to bring Medicare to all? What are they going to do? What are their strategies? What are their attacks going to be?
It's the same as they've always done, but they just have different names for the front groups they set up. And it's not just insurance companies. One of the things to keep in mind is that the big for-profit entities, insurers and providers, this is all very symbiotic of them. They want to keep the jig going as long as they can because they make money. So they're pooling their resources, they being the insurance companies, the big drug makers, the big
You're broken up.
private hospital companies, yeah. They've founded this organization called the Partnership for America's Healthcare Future, and it's run out of a big PR shop in Washington, and that's where they're going to be creating and pushing out all their propaganda, and it's underway already.
What are they going to do?
They intimidate. They try to intimidate members of Congress. A lot of their work is focused on trying to persuade Democrats in particular, and they can do that to a large extent. One of the things we do at Tarbell is looking at how much money a lot of the Democrats are taking from healthcare special interest. And stay tuned, watch this space, because we'll be showing more and more about how they're able to do this, how they go about doing this, and trying to peel off Democrats from supporting this. I think this time they're not going to have as much success as they have in the past, because the support for Medicare for all is real and growing.
All right, and we've got a wrap. My guests for this show have been Wendell Potter, who's the founder of Tarbell.org, an amazing investigative news site which you really should sign up for and check out and support, and Chuck Pennacchio, who is a history professor at University of the Arts, Philadelphia, and he's the coordinator of Payor States Network. Thank you both so much for being on the show.
Thank you, Rob.
Real pleasure. Thanks, Wendell.
Thank you, Chuck.